Good evening, welcome, and thank you for attending tonight's Ahead of Cancer lecture series sponsored by the Allegheny Health Network Cancer Institute. My name is Michelle Studnicki, and I'm one of the project coordinators for the Cancer Institute. There are a few housekeeping items that we need to review before we start. The first one is during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time permits. 2, participants cannot speak during the conference, but again, we encourage feedback via the chat option. Third, tonight's lecture is being recorded. If you're interested in rewatching this lecture or any of our past lectures, please check out our YouTube channel. The entire lecture series is posted under the Head of Cancer playlist. Lastly, if you would like to schedule an appointment or have any questions regarding a potential concern, please call our Hope line at 412-578-HOPE to schedule an appointment. Our topic tonight is Know Your Skin, Catch Melanoma Early. And just as a caveat, the month of May is Skin Cancer Awareness Month. So this ties in perfect. We are pleased to welcome Dr. Charles Mount, Dr. Ranjita Pallavi, and Dr. Deanna Huffman this evening. I'd like to take a moment to briefly introduce these remarkable individuals and showcase the impactful work they're doing right here at Allegheny Health Network. Dr. Mount. Dr. Mount is a distinguished dermatologist and co-director of the AHN Cancer Institute's Skin Cancer Center. His clinical expertise encompasses a broad range of dermatological conditions, including the diagnosis and treatment of skin cancer, psoriasis, atopic dermatitis, autoimmune and connective tissue diseases, and contact dermatitis. Dr. Mount is known for his comprehensive approach to patient care and his dedication to providing the latest advancements in dermatological practices and medicine. Dr. Mount earned his medical degree from the West Virginia School of Medicine in Morgantown, West Virginia. Following medical school, he completed his residency at the highly regarded Washington University of Medicine, the Barnes Jewish Hospital Dermatology Division in St. Louis, Missouri. Dr. Mount is certified by the American Board of Dermatology. Dr. Mount is an active member of the American Academy of Dermatology and the Medical Dermatology Society, demonstrating his commitment to professional development and contributing to the field of dermatology. Next speaking, we will have Dr. Ranjita Pallavi. Dr. Pallavi is a board-certified hematologist and medical oncologist with special clinical interest in melanoma and other solid tumors. She currently serves as an attending physician at the Allegheny Health Network Cancer Institute in Pittsburgh, Pennsylvania, where she provides comprehensive oncology care with a strong emphasis on patient-centered treatment, multidisciplinary collaboration, and community outreach. Dr. Pallavi completed her medical education at the KJ Somaiya Medical College and Research Center in Bombay, India, followed by residency training in internal medicine in both India and New York City. She subsequently completed her hematology and oncology fellowship training at Westchester Medical Center in Valhalla, New York. Her clinical practice includes the management of multiple solid tumors and hematological malignancies, including breast, lung, gastrointestinal, and hematological cancers. However, her primary passion and focus has been melanoma, particularly in the areas of early detection, immunotherapy, patient education, and improving outcomes through personalized cancer care. In addition to her clinical work, Dr. Pallavi is also actively involved in patient education initiatives, cancer awareness programs, and multidisciplinary tumor board collaborations aimed at advancing cancer care across the region. And last but not least, we have Dr. Deanna Huffman. Dr. Huffman is a dedicated medical oncologist with the Allegheny Health Network, specializing in the diagnosis and treatment of complex skin cancers with a particular focus on melanoma. Her training includes a residency completed locally at the Allegheny General Hospital right here in Pittsburgh, followed by a fellowship at the Louisiana State University in New Orleans. Beyond her clinical responsibilities, Dr. Huffman also serves as an associate professor with the Drexel University College of Medicine. Her research endeavors, while encompassing the real-world costs and disparities in lung cancer care, are further informed by her comprehensive understanding of the cancer biology, making her insight into skin cancer particularly impactful. So welcome, doctors. I think we're going to start with Dr. Mount first. So Dr. Mount, take it away.
All right, thank you for the introduction and having us on tonight to talk about skin cancer and why it's so important for everyone to be able to know the basics on trying to, what to look for on your own skin, your family member's skin, for those on the line that are not physicians or healthcare providers. Um, Being the most common skin cancer, it's the most likely to affect us or our family members. So it's essential for education and just getting it out there to know how we can help each other. Let's go ahead and advance my next slide, please. No financially relevant disclosures for this talk tonight. Good. Next slide. So why is this important? Again, extremely, extremely prevalent in our society and humans. You can see there's at least about 3 to 4 million or over basal cell carcinomas annually in the US. And there's more annual cases of skin cancer, more than prostate, breast, colon, and lung cancers combined. So when you start looking at stats like that, 1 in 5 Americans, by the time they hit 70, are going to develop some form of skin cancer. Now, thankfully, that's typically the much more common and less dangerous type of skin cancer that are non-melanoma skin cancers. So you'll see that NMSC there, basal cell carcinoma, squamous cell carcinoma. Another name for that is keratinocyte carcinomas. But rather than more deadly cancers like melanoma or Merkel that we'll touch on. But most of these cancers are associated with ultraviolet radiation, which is a risk factor that we can mitigate. And when patients have one skin cancer, unfortunately, they're much more likely to advance and to have another primary skin cancer in the next few years. Next slide. So how dangerous are these skin cancers, and a little bit more data on how prevalent they are. Data has been presented that there's one person that dies from melanoma every hour. There's over 230,000 cases of melanoma in this year. And again, most of those are attributed in one way or the other to ultraviolet exposure. That could be outdoor or indoor tanning. If you've had more than 5 sunburns, your melanoma risk doubles. I grew up in the 80s and the 90s, and I've definitely had more than 5 sunburns. So I think that affects a lot of individuals, especially with fair or even medium skin. And what I think a lot of patients don't realize is that 20–30% of melanomas come from existing moles. Everybody's paying attention to moles they have, but really most of the moles or most of the melanoma comes from normal appearing skin, de novo perhaps, not from a pre-existing benign nevus or mole. Next slide. So again, more statistics here. All these cases, thankfully, most of those melanoma cases are going to be stage 0 melanoma in situ, which are typically not life-threatening, and less than half will be more of invasive. It typically is a male-predominant disease, and of the people that will be expected to pass away from melanoma, about a 3-to-2 ratio of men versus women passing away. Next slide. I won't belabor the stats, but you can probably read them here for yourself. Melanoma predominantly is felt to be a male burden disease. Melanomas in younger patients, and typically in their 30s and 40s, are typically female, whereas most melanoma occurs in males across the human species, but most melanomas occur in patients, over the 50 years of age, more like 50 or 60 years old. When we catch it early, melanoma survival is great. So if across all stages, it's 95%. If you catch it in the earliest stages, that's early thin stage 1 or melanoma in situ, the survival is over 99%. But when it gets into the lymph nodes, it drops down to 76%, and stage 4 metastatic disease, 35% survival, respectively. Next slide. 1 in 33 Caucasian or white men will develop melanoma. 1 in 50 white women will do so. And it's much less common in darker races, specifically black skin. However, you can see the survival disparity there. 70% survival for blacks versus 93% or 95%, as we stated earlier, depending on what stats you look at, for white patients with melanoma. There's been thought and data over the years that darker skin patients, the type of melanomas they get, which are typically acral skin on the hands, feet, and nails, or mucosal, can be more aggressive. And my colleagues, Dr. Pallavi and Dr. Huffman, can weigh in on this as well, and their input and their data. But acral skin, nail, and acral melanoma, not necessarily more aggressive in my opinion, but the diagnosis is often delayed, unfortunately, and that can account for some of that survival disparity. So whenever I have the chance to meet with patients of darker skin tone, even if they're not there for a skin cancer check, if they're there for rashes and we're looking at their hands and feet, I try to take the time to bring up like, hey, you can get skin cancer too. It's typically on your hands and feet and nails if you're going to get it, although it's very unlikely. Just to pay attention to those areas because a lot of patients of color don't realize that that's where they're going to get skin cancer if it happens. Next slide. The risk factors, as we've gone over, it has to do with the ultraviolet radiation, cumulative, meaning the sun you get all the time over minutes and hours and days and weeks versus intermittent exposure. Indoor tanning is such a bad idea, and we know that it's tied to increased risk of non-melanoma and melanoma skin cancer. So, when we see recently statements made by certain officials that they're going to roll back the ability of minors to do indoor tanning, most dermatologists are cringing. And all the work that we've been doing over the last several decades to promote public awareness of how bad tanning is for everybody, especially people that are young, we can't let the public think that indoor tanning is safe for anybody, but especially our young minor patients. Next slide, please. So you can see how bad the indoor tanning risks are there, okay? Significant increases. If you've ever tanned, your risk of getting skin cancer with indoor tanning is worse than if you smoke, getting lung cancer. And it's a lot worse the younger you are. Next slide. So let's talk about some non-melanoma risk factors. There's other chemical exposures that can increase besides UV. It's usually occupational related to chemicals. Smoking can be one of them, depending on the body site, the lips and the fingers. HPV or human papillomal wart virus. There's high-risk strains, there's low-risk strains. Low-risk strains cause common warts on our skin. High-risk strains can lead to certain oropharyngeal tonsillar cancers, cervical cancers, anal cancer, and skin cancer. So typically when we see squamous cell carcinoma on the digits, there is an high-risk HPV strain involved, but just know that it can cause skin cancer elsewhere. Next slide. And we know by testing the DNA of skin cancer, squamous cell carcinoma typically contains more human papillomavirus than normal skin, and our immune-compromised patients in general harbor more HPV viral load than immune-competent patients, and we'll talk that those patients are a significantly higher risk for subsequent squamous cell carcinoma. Next slide. Immune suppression, you can see here, HIV, it historically has increased skin cancer rate significantly. So all HIV patients, we recommend once a year skin checks. That rate has dropped quite a bit over the last several years just because antiretroviral therapy has gotten so much better. But it's still a risk factor. Organ transplantation, kidneys, liver, heart, lung transplants being the highest risk, they really increase the skin cancer burden and risk to those patients. It's really essential they get annual full body skin checks with a dermatologist. Next slide. So let's talk about what skin cancers look like. Actinic keratoses, these are what we call precancers as dermatologists a lot of times. The risk of developing into squamous cell carcinoma of the skin is something like 10 or 20% over 10 years. So we call them precancers. They don't all become skin cancer, but they can, and that's why your dermatologist might freeze them, might treat them otherwise with topical medications. Next slide. And this is what they're trying to become, these non-melanoma keratinocyte skin cancers. Next slide. When it's stage 0, this is squamous cell carcinoma in situ, or sometimes we call that Bowen's disease. That's a squamous cell carcinoma. Think about it as whenever we say in situ, that typically means it's confined to the outer layer of that tissue, in this case, what we call the epidermis. Think about your skin as a cake with icing, and the icing is the epidermis. And if the cancer is, whether it's melanoma or squamous cell carcinoma, if it's isolated to the cake icing, that's in situ stage 0 disease. And that's a very, very good thing. It's caught as early as possible. We may not need to do surgery for it. If it's a squamous cell, we can treat it with creams. If it's melanoma, it still needs excise, which we can touch on, but this is caught as early as possible. Next slide. When it gets invasive, it's going to look more like a tender, like keratotic, rough papule or nodule, kind of like a volcano. And there's certain areas of our body that are higher risk for spread of the disease internally, like the lip, the ear, and potentially the anogenital skin. There's certain risk factors that we look at under the microscope that also upstage how risky this tumor might be to the patient. Next slide. And this is a specific version. These are a more common subtype of squamous cell carcinoma. So if you are diagnosed or family member is diagnosed with a keratoacanthoma, that is a type of squamous cell carcinoma. The textbooks say these things historically, and some patients have spontaneously regressed. I don't think in 2020, whatever or beyond, that most dermatologists or surgeons would wait for one of these things to spontaneously regress. I have actually seen that happen, and patients show me a picture of one, and they came to me, and by the time they got to a dermatologist, it actually had regressed. We would still, of course, biopsy the area and make sure the cancer was gone. But typically, if we see this, we manage it as a squamous cell carcinoma and excise it, or otherwise treat it as a cancer. Next slide. And these are just variants. You know, they're typically tender. They typically look kind of like this crateriform, crusty, maybe bleeding. But tenderness is one of the signs that often differentiates squamous cell carcinoma from basal cell carcinoma and melanoma and Merkel cell, even more dangerous skin cancers. These things typically hurt because they like to grow around nerves. Next slide. And just you can kind of see where it comes from. These rougher, smaller, flat, pink, scaly, non-tender lesions that happen in chronically sun-damaged areas, typically in fairer skin individuals, progress onto these squamous cell carcinomas. Next slide. That tenderness, this is just a study that has shown the correlation in terms of tenderness. It's the one thing I look at. If I look at a precancerous lesion on a patient, I'm often touching it or asking the patient, does it hurt? If I touch what I think looks like a precancer and the patient backs away from me, or, you know, looks at me like I'm an idiot because I just caused them pain, that's an indicator for me to know that it looks like a precancer, but there might be invasive squamous cell hiding underneath there, and that can be the tipping point that I decide to biopsy it. Next slide, please. Let's move on to more common basal cell carcinoma. So again, remember, there's about 4 million of these a year in the US. There's about 3 million a year of squamous cell carcinoma. So this is the most common skin cancer in humans, in particular fairer skin races. Next slide. And it typically looks like this pearly, translucent papule or plaque. It often has this rolled border. You can see that big red blood vessel in there. We call them arborizing blood vessels. It looks like a tree growing across it. There's subtypes. The most common you're seeing most of these pictures here are what we call nodular basal cell carcinomas. There are pigmented versions you can see in the bottom right. They look sometimes almost like a melanoma. Usually you can tell up close that there's a difference there and it's not a melanoma, but it can be confusing in certain patients. Next slide. This is what your dermatologist sees when they're using a dermatoscope, that handheld little fancy looking flashlight. And this is what we're looking for with those vessels and those little pigment globules on the periphery. Next slide. This is what we see under the microscope, these islands of these basaloid looking cells, and they kind of retract from the surrounding epidermis. And the reason I'm showing you histology is because I kind of use this in another slide moving forward. Next slide, please, to show you differences on what it looks from a superficial basal cell. And these are not uncommon as well. These can look like a little rash on a chronically sun exposed area. It could look, honestly, not like much. This is a pretty good classic picture, but they can often be really, really subtle, you know, only a few millimeters across. And then this is another analogy where I like to tell patients, you can see in that histology, that slide picture, these tumor cells are growing like a little oil slick. If you imagine like oil droplets on the top of water, they kind of just float instead of invading into the skin. And that's generally a good thing because it's not growing inwards, which is what we don't want cancer to do. But the problem is they can, you know, if you slapped the surface of the water where an oil collection was, the globules can kind of break apart or calve like a glacier does. And those little islands can spread further away from the clinically identifiable tumor. And that makes these a little bit higher risk for recurrence when you do excise them. So sometimes using topical chemotherapy creams can work better, or even a procedure called an ED&C where we just broadly scrape the surface of the skin off. Next slide. And you can see the similarities of squamous cell carcinoma in situ, a stage 0 squamous cell carcinoma, and a superficial basal cell often have very similar clinical features when you look at it. There's things we can see on dermoscopy and other cues, you know, when you look at these enough, but they can look very similar, if not the same, to the naked eye. Next slide. Subtypes of basal cell, there are higher risk ones. This is a more morpheoform or infiltrative. They often look like a scar. So what I tell patients, if I see something that looks remotely like this, I say, did you have a procedure? Did you have a surgery? Did you have an accident that would create a scar? I don't like scars in middle-aged or older patients that don't have a story behind them. If a patient has a scar-looking bump or growth into their skin, especially the nose where these typically like to happen, or on the lip, they have a scar and they don't know why, That's oftentimes is a reason that I might have to do a biopsy to see if there's basal cell actually growing into the skin to create a scar-like appearance from the surface. Next slide. And these are just a little bit different. There's subtypes, there's low risk, there's high risk. And just to kind of give you a understanding that, sometimes your dermatologist is really worried about a basal cell and sometimes we're not. And that's why, because some of these can be really nasty, grow inwards, grow around nerves and underlying structures, and some of them just literally grow up on the surface of the skin. Next slide. Let's get into melanoma, the one that gets all the buzz appropriately so. Next, please. Lots busy slide, but I just did this to show the heterogeneity of what melanoma can look like on the nails and the feet and different areas of skin. Next slide. These are the four most common subtypes of melanoma. The number one being superficial spreading melanoma. This is typically what we see in most patients. Nodular, not as common, thankfully. These typically are more aggressive in terms of metastatic potential. Acral lentiginous melanoma is what grows on the acral skin, means palms and soles. So that's what you see on the palms and soles, and that's what's more common in people of color. And then lentigo maligna is something that you typically see on chronically sun-damaged skin of an elderly, fairer-skinned individual. Thankfully, these typically are a little bit less aggressive in terms of metastatic spread, but they have a higher local recurrence, unfortunately, after surgical resection. Next slide. What should patients and non-dermatologists be using, even a dermatologist, when we're looking for skin cancer, particularly melanoma? You're looking for lesions that are asymmetric, have an irregular border, more than one color. I don't like multiple colors, no more than 2 or 3 shades of brown, or if there's another color in there, like if there's pink with brown or something like that. D is diameter. Typically, we want things to be less than 6 millimeters or the size of a little pencil eraser. If it's bigger than that, that's a concern. E is for evolving or changing. So if it's rapidly changing over a matter of weeks or months, that should raise your concern. Next slide. What I like even better for patients is the ugly duckling sign. So think about all your moles. If you crammed them into a family photo, kind of like this diagram is trying to portray here, take all your moles, you cram them into a family photo together. They all should look like siblings or maybe at least cousins of one another. They resemble each other in terms of shape, texture, the color, relative size to one another. If there's an ugly duckling that doesn't belong in the family photo, that probably needs evaluated, maybe a biopsy with a doctor or a dermatologist. And there's different ways that an ugly duckling sign can stand out, and this illustrates that pretty well. Next slide, please. This is that superficial spreading melanoma. You can see it's just kind of growing very superficially across the skin there, but there are areas that are diving deeper, invasive components. Next slide. Nodular, bigger picture here, looks like a big mass. Next slide. Acral, you can see they're kind of hard to tell, especially early on. That can be kind of very ill-defined. You really have to look for them depending on, the positioning of the patient, the lighting of the room, their background skin color. Next slide. And then there's nail melanoma. And nail pigmented lesions are not uncommon. We call that longitudinal melanonychia. It's actually a really high proportion of patients of color, particularly African or Black skin patients, will more often than not have some amount of melanonychia by the time they hit 50. It's much less common in Caucasian patients. It is a little bit more common in Eastern Asian patients. So we see melanonychia quite a bit, and there's things that you look for to differentiate it from potential nail melanoma. This is a pretty obvious picture of nail melanoma, but things you want to look for when you're looking at your finger, the end that's backed by your cuticle, if it's wider than it is at the end of the nail plate, where you cut your nail or you trim your nail, that means whatever's back here is growing, and that we have to make sure that's not a melanoma or versus just a benign mole in the nail unit. If it's ever the pigment's ever getting into the skin, we call that Hutchinson sign that you can see in that photo there. That's a concern that needs a biopsy. If it's bigger than 4 or 5, 6 millimeters, then we're going to biopsy it, of course. If a patient has multiple streaks on their nails, which is not uncommon, again, the ugly duckling sign comes into play here. If they have one band or one finger that looks a lot different than the others, that ugly duckling sign may be what tips us off to biopsy that nail unit in terms of pigment lesion. Next slide. This is that lentigo maligna melanoma. It can be really hard to differentiate from seborrheic keratoses and benign lentigo or benign sunspots that folks in their 60s, 70s, and 80s will commonly get. There's discerning features we can look on dermoscopy. Again, we use that ugly duckling sign to see what stands out here. Next slide. This is honestly, I take care of patients in the burn unit and the bone marrow unit, people with life-threatening autoimmune blistering skin diseases, and I usually don't flinch or bat an eye or ever get anxious about treating very, very sick patients in those scenarios. But this is what keeps a lot of dermatologists up at night. An amelanotic melanoma, when a melanoma doesn't look like a melanoma, in this case, can look like a benign, what we call dermal nevus, the kind of squishy moles that a lot of people have on their face or head, neck, or even another type of benign thing called a keratosis. There's features that we see on dermoscopy, but this is the one thing that even somebody that sees a lot of melanoma unfortunately can miss because they're just pretty sneaky and benign appearing a lot of the time. Next slide. This is what I half jokingly call job security for dermatologists, because these are these benign wisdom spots, these seborrheic keratoses. And you can see this breaks all the rules I just told you to look for that every dermatologist tells people to look for, right? These things show up quick. They start showing up in our 40s and 50s when we're starting to think about or see cancer and skin cancer develop in our family members and our friends. And everybody gets them. So that's when I joke to patients, these are job security for dermatologists because they're super common and they break every single ABCDU ugly duckling rule there is. But they're pretty easily identifiable once you get comfortable looking at skin lesions. Next slide. They had kind of this waxy, velvety appearance on the surface, and we use that, again, that scope that we carry around that helps us really hone in on these. Next slide. Merkel cell, real quick. That's unfortunately the type of skin cancer that Jimmy Buffett passed away from. They look like kind of chronic pink bug bites is often what our patients tell us they thought they had. Not as common, but these can be much more aggressive than melanoma. Next slide, please. Skin cancer management. I won't touch on this too much for the purposes of this talk, but just know that skin cancer ideally is almost always treated early on surgically because that can be most definitive. For superficial and non-life-threatening things, we can do non-surgical skin-directed things like topical chemotherapy creams and photodynamic light therapy in a doctor's office. Of course, I'll let all my colleagues comment on more systemic and aggressive treatments and radiation if that's part of the talk tonight. But ideally, if we get it in stage 0, stage 1, or even 2, skin cancer, surgery is almost always curative. Next slide. For non-melanoma skin cancers, again, we can scrape them off. Sometimes we do routine wide local excision with standard margins and also utilize Mohs micrographic surgery. Next slide. Just real quickly on the margins, we don't have to get into this too much, but just noted how wide we cut out for these skin cancers, in particular melanoma, really is the determining factor. How deep it is in the skin is how determines how wide we have to go. Next slide, please. That's all I got. Sorry if I ran a little bit over for my colleagues here, but I think we'll move on to the next section.
Can everybody see the slides?
Yes, everything looks great.
Okay, all right. So the oncology has really changed over the last several decades, and most of the cancers these days we kind of have a multidisciplinary approach. Initially, we treated people with surgery, radiation, chemotherapy, but as time has passed, we're looking more at like targeted drugs, immunotherapy, molecular testing, and treatment sequencing to come up with the proper plan for an individual patient. This has become especially important for melanoma because this was considered to be one of the most difficult cancers to treat in the advanced setting in the past. However, now with immunotherapy and targeted therapy, outcomes have improved significantly for many of our patients. However, it's important to remember that even with the modern treatment, early detection is still the most powerful tool. Dr. Mount already touched upon these things. Just to go over a few brief things, remember that this can be amelanotic in less than 2% of the patients. Almost 2/3 of the melanoma do arise de novo. The sun damage increases the risk overall. This is just an image of the skin, just because I will be talking about the staging, just to go over the 3 layers that we look at. The epidermis is the top layer of the skin that contains the melanocytes. The second layer is the dermis, which contains the blood capillaries, lymphatics, all of the nerve endings, as well as glands and hair follicles. And the lower part of the image actually looks at the hypodermis, which is the fat, connective tissue, blood vessels, and nerves containing area. Dr. Mount already mentioned about the ABCD criteria, very helpful in for the workup for these suspicious skin lesions. He also went over the 4 classic types of the superficial spreading nodular melanoma, the lentigo malignant melanoma, as well as the acral lentiginous. Just a few other unique melanomas, because I will be focusing mostly on the cutaneous melanoma treatment. Just wanted to mention briefly, there is an entity called desmoplastic melanoma. These tend to be very immunogenic. They have very high, something called as tumor mutation burden, which makes them very responsive to immunotherapy. The response rates to immunotherapy for these desmoplastic melanomas can really exceed about 60 to 70%, and some of them can be really dramatic and durable responses. The mucosal melanoma, they are very different molecularly as well. They arise from the mucosal surfaces, such as the nasal cavity, sinuses, oral cavity, the GI tract, particularly the anorectal area, vulva, vagina, the urethra. These are areas that are not related to sun exposure. As I mentioned, they do have a different mutational profile, so they carry lower BRAF mutation rates. They have higher number of KIT mutations, which makes them very targetable for these targeted drugs called, which are the KIT inhibitors, such as Gleevec. The mucosal melanomas do tend to be more aggressive. They have higher metastatic potential. Overall, they have a lower TMB, less responsive to immunotherapy agents. The prognosis generally tends to be worse for these melanomas. The third kind, the rare type, is the uveal melanoma, which typically arises from melanocytes in the eye. The choroid is the most common area. It could also be from the ciliary body and the iris, and they're biologically very different diseases. As I will talk later, most of the melanomas that we see in the skin have the BRAF mutation. I mentioned about the KIT for the mucosal melanomas. The uveal melanomas have mutations involving the GNAQ and the GNA11 mutations, and they're typically BRAF wild type. They have a very strong tropism for the liver. More than 90% of these uveal melanomas do tend to spread to the liver. They're also very aggressive, again, managed very differently. For the uveal melanoma, usually they're treated with radiation plaque brachytherapy. Sometimes proton beam therapy is used in specialized centers. Overall, they do have low response rates to immunotherapy agents. There is a newer bispecific fusion protein that's targeting something called as the GP100 on these melanoma cells. It kind of redirects the immune system to and brings them towards the melanoma cells, which has been remarkable treatment for the uveal melanomas overall. And as I said, that they have a tropism for the liver, and sometimes, when they present with metastatic disease involving the liver, we can use liver-directed treatments such as hepatic artery infusion, Y90 TACE ablation, and radiation treatment for those liver lesions. Dr. Mann already mentioned, so I'm just going to skip over the slides that mention the 4 most common melanomas. The diagnosis, if the lesion is small, an excisional biopsy is preferred. Sometimes for large lesions, as well as lesions which are in hard areas such as the face, patients get a shave or a punch biopsy. After the diagnosis of melanoma has been made, once we try to get some additional imaging. If it's locally advanced, we might get a CT scan, chest, abdomen, pelvis with contrast. Sometimes we get a PET scan to further evaluate the extent of disease, as well as a brain MRI. We also get some basic routine blood work, including a CBC, looking at a complete blood count, comprehensive metabolic panel, as well as an LDH. The LDH is a very important marker, especially for the aggressiveness of the malignancy, as well as the disease burden. And we kind of put all this information to finally come up with the stage for the melanoma. Melanoma that is just confined to the epidermis is stage 0. We use something called as a TNM staging to kind of determine the final stage for the patient. And the T stands for the tumor depth and ulceration. The N stands for the lymph node involvement, and the M is for sites of distant metastatic disease. Based on these, it could be stage 1, 2, 3, and 4, which are again subdivided. The most important factor is something called as the Breslow thickness, which actually measures in millimeters how deep the melanoma has grown into the skin. As you can see on the right of the image, less than 1 millimeters, 1 to 2 millimeters. Melanomas that are 2 to 4 millimeters and more than 4 millimeters kind of is the gross definition that looks at the T stage. Previously, Clark's level was used. It actually had 5 levels. Again, grossly, level 1 was confined to the epidermis, level 2, 3, and 4 confined to the dermis, and level 5 is beyond the dermis. However, the Breslow thickness has become more core now because, as I said, it does correlate with overall survival, the risk for nodal metastatic disease, the recurrence risk, as well as the overall prognosis for the patients. We also look at certain other high-risk features that includes ulceration, also the mitotic rate, which is how fast the tumor is growing under the microscope. I already mentioned the value for the LDH. Also, if the lymph nodes are involved, certain high-risk features under the microscope, including involvement of blood vessels, lymphatics, or the nerves in the area. The mitosis is important because patients who have a high mitotic rate, say of 5, the survival we can see from the 5-year survival is only 73% and drastically drops as the mitotic rate goes above 20. So as I mentioned, the breast flow thickness is used to determine the T stage. Grossly, we're looking at T1, T2, T3, and T4, and these are all measured in millimeters. And then they're kind of subdivided whether there's a presence of ulceration or not into A and B. The N is the nodal involvement. N1 is just metastasis in one lymph node. Again, that could be either microscopic, that is picked up on a sentinel lymph node biopsy, or they could be macroscopic, meaning that either they're clinically palpable or they're showing up clinically on one of our imaging that we've done. The N2, again, has lymph nodes involved in 2 to 3 regions, and the N3 disease involves 4 or more. The N3 also includes in-transit or satellite lesions. Satellite lesions are metastases within 2 centimeters of the primary melanoma, whereas the in-transit is beyond the 2 centimeters from the primary tumor and before the regional lymph node basin involvement. The M looks at metastatic disease, again subdivided into whether it's just metastases to the skin, subcutaneous tissue, or the distal lymph nodes, which is M1A. Spread to the lung makes it M1B, and then all other sites or any disease that has an elevated LDH makes it M1C. Dr. Mohammed mentioned that the 5-year survival is more than 95% for melanoma. However, the stage-specific survival can vary. As we can see, the survival for stage 3 patients is dramatically lower as compared to stage 1. And stage 3, the 5-year survival is 77% as compared to 1, which is 98% at 5 years. Again, among the stage 3, the survival is very different for the subtypes between the A, B, C, D. And as we see, the survival of stage 3D drastically is lower at only at 32% at 5 years. We also have found out that patients who have stage 2B and 2C melanoma actually tend to behave more aggressively, and their outcomes are similar to patients who have stage 3A and stage 3B disease. And that's why the adjuvant treatment recommendations do take that into account. Melanoma is a genetically heterogeneous disease. About 40% of the patients have a mutation called the BRAF mutation. As I mentioned, the mucosal ones tend to have more of the KIT mutation, which is otherwise less common in cutaneous melanomas. About 35% of them do not have any driver mutations. And these all have clinical implications when selecting treatment for patients who have either early stage disease or advanced disease. As Dr. Mountain mentioned, we catch it early on, we treat with surgery. We also do a sentinel lymph node biopsy if clinically there are no palpable lymph nodes or clinically not picked up on imaging. If we have any clinical suspicion for lymph node involvement, we do send patients for biopsy. There's also a role, I will talk about more about the systemic treatments in other slides. He already mentioned about the surgical margin goals, depending on what the thickness of the tumor is and what margin is recommended by the national guidelines. The first lymph node that drains the fluid from the tumor is the sentinel lymph node. Lymphoscintigraphy or methylene dye is used to determine that. And this is done only if the lymph node is clinically not palpable. As I mentioned, if the lymph node is palpable, we send the patients for biopsy. Sentinel lymph node biopsy is done for patients when we consider that the risk of lymph node involvement is more than 5%. And this usually is the case if the tumor thickness is more than 1 millimeter. Sometimes we also consider sentinel lymph node biopsy for tumors depth greater than 0.8 millimeters. High-risk features, again, as I mentioned, high mitotic rate, the lymphovascular invasion, ulceration. These are all considered very high-risk features, and patients would benefit with the lymph node biopsy that would upstage them. Regarding the adjuvant treatment, so when we catch melanoma early on for stage 2B, 2C, and stage 3 disease, the option is to do treatment either after or before. Classically for 2B, 2C, as well as stage 3 patients, as per NCCN guidelines, adjuvant treatment is recommended. There were 2 big clinical trials, Keynote 716 and the Checkmate 76K, that looked at using adjuvant immunotherapy with either Keytruda or Opdivo for about 1 year that improved the recurrence-free survival. And this is what is recommended as per the cancer guidelines for stage 2 melanoma. Same thing for stage 3 also. For all stage 3 patients, adjuvant treatment with immunotherapy is recommended. We also recommend checking a BRAF mutation. As I said, almost 40% of the patients have BRAF mutation. And it could be a BRAF V600E or K mutation. And there was a big study called the COMBI-AD trial that looked at using these BRAF combination drugs as compared to doing nothing in the adjuvant setting. And all of this was associated with improvement in the recurrence-free survival. There has been more focus about trying to use these treatments now before surgery, and we do want to identify those patients. Again, there was a big trial called the Deanna trial that has been practice changing. This looked at patients who have stage 3 macroscopic disease, where they had 2 doses of a combination of immunotherapy medications known as nivolumab and ipilimumab. So these 2 drugs were given together every 3 weeks for 2 cycles, and then the patients had surgery. At surgery, we kind of looked at what the response was. Patients who had a major pathologic response, meaning that they only had less than 10% of the viable cells present, actually did not need any treatment. And almost 60% of the patients on the clinical trial had a major pathologic response and did not require anything, meaning that patients who have advanced stage 3 disease pretty much can have durable responses just with 2 doses of immunotherapy given before surgery. If they only had a partial response or did not respond, then there was immunotherapy given after surgery for about a year. If they had a BRAF mutation, then we did the BRAF drugs for about a year. And all this has really been practice changing. And this has become a more multidisciplinary approach now for patients, as I mentioned, who are diagnosed with stage 3 disease, will benefit with treatment, couple of doses of immunotherapy upfront. That has improved overall recurrence-free survival. What is the rationale of adjuvant versus neoadjuvant immunotherapy? So obviously, if the tumor is taken out and then we're giving somebody immunotherapy, the antigens are far less and the immune response is far less, as compared to when the tumor is already in situ and then we're giving somebody immunotherapy, that's able to activate a lot of T cells, and then the surgeon removes the lesion, and we see that there are many more very diverse T cells that's able to search for the tumor cells and effectively kill them. This is, so I said that adjuvantly we're using a combination of immunotherapy drugs. All of them, the basic concept is they're targeting these immune breaks on the immune system. So this is looking at ipilimumab or Yervoy, which is a CTLA-4 blocker. And then we have drugs such as nivolumab or pembrolizumab, which target the PD-1. So these are, again, immune breaks that the T cell the cancer cells are kind of blocking it, so they're not able to identify and kill the cancer cells. When we give these immune blockers, they kind of release the brake on the immune system, and then the activated T cell is able to kill the cancer cells. The CTLA-4 blockers act more for the early priming of the T cells, which typically happens in the lymph nodes, whereas the PD-1 blocker, they act more in the tumor microenvironment. And using the 2 in combination obviously can really improve on the response rates that we can get. This is the Deanna trial, as I mentioned, where we use that immunotherapy before surgery, and then the patients went for surgery. Clearly shows that significant improvement in the event-free survival for patients with this approach, and that truly has been practice changing. Cytotoxic chemotherapy is rarely used anymore because melanomas do not respond to that. The role for radiation has been limited, maybe considered if the margins are positive, if there are multiple lymph nodes involved, if there's extra nodal spread. For patients who have stage 4 disease, we also use radiation for symptom relief. Any bone metastases for palliation, spinal cord compression, as well as brain metastatic disease do benefit from radiation treatment. I'm just going to skip over the immunotherapy. This I kind of went over the 2 areas. One of the early stages, the T cell activation that happens in the lymph node, which is a priming agent, and most of the time the Yervoy or the CTLA-4 blockers act at this stage. And then the second phase is the tumor microenvironment, where we have the PD-1 and the PD-L1. The PD-L1 is a ligand that's on the tumor cell that's putting a brake on the PD-1 on the activated T cell. And by blocking these interactions is how we can get our immune system to fight the cancer better. They're also looking at certain personalized cancer vaccines now. So this is patients who've had surgery. Now, I told you that if they have virus disease, they get Keytruda for a year. They're trying to combine this personalized neoantigen treatment. So from the patient's tumor, they kind of come up with a messenger RNA that's very much specific to the patient's tumor. And it has up to 34 neoantigens. And they're using that in combination with the Keytruda after the tumor was taken out. And that has clearly improved, again, the recurrence-free survival for patients at the 3-year mark compared to just using Keytruda again. This is not approved by the FDA yet, but this looks very promising. For patients who have metastatic disease, we kind of use similar treatments. It could be a combination of the immunotherapy, as I mentioned, with the Yervoy and the Opdivo. It could be Keytruda. They're also looking at other immune breaks. One of it, again, is this LAG3. Again, as I mentioned, if we look at the tumor cell and the activated cell, these are all immune breaks that does not let the immune system function and fight the cancer. There is a combination of PD-1, which is the nivolumab, in combination with this LAG3 inhibitor called relatlimab, and the combination is called Opduolag, which is able to function slightly better than what the PD-1 itself will do. By combining these two, we increase the efficacy and don't really increase the toxicity like how we see with the Yervoy and the Opdivo, and we get similar benefit from this combination. There are also newer agents looked at. The newest one is this called lifileucel, which is a TIL treatment. Again, it's based on the concept that the tumor has a lot of these enriched T cells. That's the body's T cells identifying and fighting the cancer cells. So in this case, the patient's tumor is either taken out or there could be a core biopsy. And then we are expanding all those T cells from the patient's tumor, enriching it in the lab, expanding it significantly. Then the patients get admitted, they get chemotherapy for priming and also get interleukin-2 to further expand the T cells, and that's able to kill the cancer cells effectively. Just one-time treatment. For patients who have progressed on all the immunotherapy medications or the targeted drugs, this is currently FDA approved with significant responses. We also have this treatment called T-VEC. It's an oncolytic virus, which is a modified herpes simplex virus that has been modified so that it's able to affect the melanoma cells preferentially. It also expresses something called as a GM-CSF on its surface. So once we inject like a superficial tumor or maybe a not so bulky lymph node with this injection, the virus gets into the melanoma cells, starts replicating, and then lyses it. That's how sometimes we can get some local control. Obviously, this does not work when the patients have extensive visceral metastases or if they have bulky lymph nodes, but for small tumors, this definitely can be used in addition to the immunotherapy, again, by a synergistic effect. So this is just showing that before 2011, we didn't really have anything. It was just surgery, radiation, chemotherapy. But since then, we've made a lot of progress with all these immunotherapy medications, the targeted drugs, with the TIL treatment now, T-VEC, and ever expanding armamentarium. There are also multiple things that they've been looking at. Besides the CAR-T, they also have TCR treatments, interleukins, interferons. And I think it's only a matter of time, that we can actually improve upon the survival for these patients even beyond what we have currently.
Thank you, Dr. Pallavi. Dr. Huffman?
Sure, let me pull up mine. All right, so for the last part of this talk here, I'm going to go over just some, kind of survivorship. We've talked about how to identify melanoma, how it's treated, and then I'm going to talk about a little bit what happens after, you've gone through treatment and what do you need to do next. So I want to review what the definitions of surveillance and survivorship are. Can you get melanoma again after you've already had melanoma? And what about genetic testing? Do you need to have it? Is your family going to be at increased risk? So survivorship is a period of time after you're diagnosed, and it encompasses all the physical, mental, and emotional and financial challenges related to your diagnosis. So it's really a broad term that starts when you're diagnosed with cancer and persists for the rest of your life. So this is something you may hear. Goals of cancer survivorship. This is adopted from the American Cancer Society. So really what we're doing throughout your time in survivorship is we're looking at long-term side effects. We're watching you closely for cancer recurrence. That's called surveillance. We'll talk about that a little bit more. We're trying to manage some of the challenges that come with cancer care, like the financial, social, and mental health challenges. We're trying to make sure you get plugged in with good preventative care from your primary care doctor or other care specialists that you may need. And then we'll talk about genetic counselings and whether your other cancer screenings need to be altered. So surveillance, as I mentioned, is part of survivorship. And that's the part where we talk about where we're doing close monitoring. So it doesn't mean we're doing nothing. It means we're watching you very closely through a series of blood work, physical exams, skin checks, or imaging like CAT scans and PET scans to try to watch you closely for cancer that may come back. That's called surveillance. So the goals of surveillance is try to catch melanoma that may come back as early as possible, or detect any new cancers, skin cancer or otherwise, while you're in that close period after your melanoma was diagnosed and treated. Again, we're also going to keep a close eye for long-term side effects that may result from treatment that you had. And part of it may just be to inform public data about trends, what's going on with melanoma. And potentially if you entered into research during your time in treatment, research continues throughout your surveillance period as well, like a clinical trial or things like that. So the key part of surveillance for melanoma is regular skin exams and follow-up with a dermatologist. So that lasts for the rest of your life, even after your treatment is completed for melanoma. Lab work is sometimes part of it, but it may not be required for you. And then imaging may be part of it as well, again, depending on your certain risk factors and the stage of your melanoma. The period is typically 5 years for most cancers. The highest risk of recurrence for melanoma is within the first 2 years. But melanoma does have a risk of late recurrence as well. So you're always going to want to be plugged in with your dermatologist and your medical oncologist. So just a little bit more about what we may do for blood testing. Basic lab work is not necessarily required. However, if you had a side effect during your treatment, like kidney or liver problems, your medical oncologist may want to keep an eye on that in the future. Lactate dehydrogenase and ctDNA are sometimes used as what we call tumor markers for cancer, so they can help us monitor disease. Lactate dehydrogenase, the LDH lab, that's something that may be more important for advanced melanomas. And ctDNA, so that's called circulating tumor DNA, that's where we can use lab work to detect a small fraction of cancer that may be left over in your blood. That's not FDA approved, so it's not an approved way to watch cancer, but sometimes we do that as well to monitor melanoma, especially when melanoma can be challenging to find on physical exam or in imaging. Imaging you may have are a CAT scan, a PET scan, which is like a special type of CAT scan that uses a radio tracer that's tagged to sugar, which will be eaten up by fast-dividing cells, especially cancer cells. Or you may just get ultrasounds of your lymph node area near where your melanoma occurred. And what imaging modality is appropriate to you really depends upon your stage and a risk-benefits discussion with your oncologist. So can I get melanoma again if I've already had melanoma? So 8.6, it's kind of a random number, but that's the standardized incidence ratio. So that's how likely you are to get melanoma again compared to the general population if you've already had melanoma. So that's pretty significant, 8 times more likely than someone who hasn't had melanoma. So you'll remain at increased risk for more melanomas as well as for other skin cancers. And kind of the reasoning behind this is if you had melanoma one time, that tells us that you already have risk factors present for melanoma, whether that be you've had enough cumulative sun exposure, whether that be you're a fair-skinned person that's prone to skin cancers, whether that be genetic risk factors. We know that cocktail exists for you to get skin cancers. So we can't take all of those things away. Maybe you can stay out of the sun, but we can't take back sun exposure you've already had. We can't change your genetics. So those risk factors are still going to be present. Sorry. Should I have genetic testing after I've been diagnosed with melanoma? So not everyone who has melanoma needs genetic testing. In fact, most people do not. We test melanoma tumors specifically for mutations that can help us choose therapies, as Dr. Pallavi mentioned. But that's not the same type of testing as genes that are passed down through families. That's a separate type of genetic test. We call germline genetic testing. So really what has to do, or what tells us whether you need familial genetic testing, has to do with more about your personal history and your family history. So we're looking for a cluster of cancer syndromes. So if you have multiple people in your family with melanoma, 3 or more, if you had melanoma and your sister had melanoma and your mom had melanoma, that's really more important to us as far as familial genetic testing. There's also a couple cancer syndromes, melanoma syndromes related to other cancers. So specifically, if you have a history of melanoma and pancreatic cancer in your family, or rarer cancers like renal cell carcinoma, kidney cancer, or mesothelioma, which is a type of lung cancer, we may recommend genetic testing. But again, most people will not need genetic testing. Probably true genetic melanoma cancer syndromes probably represent less than 10% of melanomas. So while you may have risks in your family, because say if your parents are very fair skinned, you're probably going to be very fair skinned too. Or if you were born and raised in a very sun exposed area, just like your parents were, you may all share risk factors without necessarily sharing genes that put you at risk for melanoma. So sometimes we see melanoma clustering in family, even though we don't find genes related to melanoma. So is my family at increased risk? It sounds like the same question, but it's actually a slightly different question that I'm asking. So if you've had melanoma one time, are other people in your family at increased risk? And so again, independent of genetic testing, your family members are still at increased risk. Having a first-degree relative with melanoma will increase your family members' relative risk by 74%. That's pretty significant. And again, those are for shared risk factors like I talked about. Like if you're fair-skinned, that's probably because your parents were fair-skinned too, or because of where you all grew up and lived in the same environment, things like that. So everyone should have annual skin exams, but definitely if you have a family history of melanoma, you should recommend that your siblings and that your children are getting regular skin exams as well. These risk factors are individualized, and we have different types of risk calculators that can tell us about your personal risk and your family's personal risks. So for family members, if you've had multiple relatives with melanoma, especially at a younger age of diagnosis, like age younger than 30, those are things that may increase your risk even more versus like a single parent who had melanoma that was diagnosed at age 80, which is less likely to increase your risk as robustly. So the overall risk is still pretty small. There's only about 100,000 new cases of melanoma in the US per year. And as Dr. Mount mentioned, a lot of them are caught at early stage and don't become deadly. But of course, you want to be aware of your personal risk and your family's risk and make sure you're getting screened appropriately based on your risk. So in summary, melanoma care doesn't end just because your treatment was completed or because your cancer was removed. There's whole stages of treatment and surveillance we move into after. That's survivorship and surveillance, where you may be getting frequent doctor's appointments, skin check, lab work, imaging, things like that. It's really important to know your family history and your personal history to understand your level of personal risk of melanoma, whether this could happen to you again, whether your family is at risk, whether genetic testing is needed. So it's really important to take charge of your own health and prevent any additional cancers and protect your skin from UV radiation, even before you're ever diagnosed with a skin cancer, but certainly once you've received that diagnosis as well. If you have any questions about any of these things, of course, you can talk to your oncologist about it. You can find more information on our skin cancer website, the AHN Cancer Institute. We have a melanoma and skin cancer center. So that's all I got.
Thank you, Dr. Huffman. I know we're just close to time, but we do have one question. I will put it out there. It is, I had a stage 0 acral melanoma on the bottom of my foot. It popped up next to a mole that I've had my entire life. I am Caucasian. Chances of having another melanoma are increased, ? I guess, are the chances of having another melanoma increased?
Yes. I mean, I can take that one. I'm still unmuted. But yes, any melanoma diagnosis will increase your risk factor of having another melanoma. So, it sounds like you're fair skin. That will increase your risk. It sounds like, whether your melanoma may or may not have been from sun exposure. As I mentioned, it seems like you already have some risk factors in your genetics and in your skin that's going to make you prone to melanoma. So it's really going to be important for you to follow up with skin exams at minimum once per year, but probably more than that based on what your dermatologist is recommending, because you've already had skin cancer once.
Okay, and another question is, on children under 18, should they be screened for skin cancer, or is that part of their regular routine with their pediatrician?
I can field that one. You may get different opinions from different dermatologists. I think that most dermatologists will probably recommend having pediatric patients be monitored by their parents closely. What I always tell parents is they don't need a baseline. Every pediatric patient doesn't need a dermatologist baseline check. I encourage my parents of those patients to keep an eye on their moles. If they have a concern, they should bring them to a dermatologist or a pediatric dermatologist. I think, when they see their pediatrician, they're, typically for their well child visits, they're typically undressed or mostly undressed, and bring up those concerns with the pediatrician. But no, I don't think pediatric patients as a routine need a screening exam by a dermatologist if there's no concerns by the parent or a pediatrician.
Okay, and last question as a follow-up to that, is sunscreen safe for children?
Yes, multiple human studies have shown no statistically increased risk of medical complications from sunscreens that are approved in the US. The one caveat is infants. It's generally recommended that on your, babies less than a year old, that you use physical sunscreen agents. So that's zinc oxide and titanium oxide. Their skin has a little bit more penetrance potentially, and their body surface area to overall volume of their body is a little bit more skewed versus an older child or certainly an adult. When when various sources online talk about, risks with sunscreen agents, whether they're chemical blockers, physical blockers, whatever, uh, being posed to humans, the data that they will often quote are mouse model studies that the poor mice were exposed. Basically, the human, to get the equivalent exposure, you basically would have to bathe a human head to toe in sunscreen for over 100 years. So much more exposure than is frankly humanly possible to get any kind of potential statistical risk in terms of hormonal change or cancer or anything like that. My daughter's 10. I've never hesitated to put a chemical or physical sunscreen agent on her skin rather than her getting a sunburn, if that's helpful.
Okay. So if there's no other questions, we would like to thank everyone for attending tonight's Ahead of Cancer lecture. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded, and if you're interested in rewatching tonight's lecture, check back on our YouTube channel, the AHN YouTube channel, for the full playlist, I should say, of all of the cancer screening videos. I would like now to thank you, Dr. Mount, Dr. Huffman, and Dr. Pallavi for this excellent presentation tonight. Thank you, and have a great evening, everyone.